हाँ, स्ट्रीम नहीं हुआ। हाँ, मेरा लिंक तो ओपन है बट स्ट्रीम नहीं हो रहा। सो हाय, अब लास्ट पेज चल रहा है एग्जाम का। आई नो यू ऑल मस्ट बी वेरी स्केर्ड एंड यू ऑल मस्ट बी वेरी एंक्शियस ऑल्सो। तो वी हैव कम अप विद सेशन ऑफ दिस सेशन ऑफ ऑप्थेल्मोलॉजी। अभी इसमें व्हाट आर वी गोइंग टू डू? वी आर जस्ट गोइंग टू रिवाइज द इम्पॉर्टेंट इमेजेस एंड द इम्पॉर्टेंट टॉपिक्स। कोई क्लासिफिकेशंस है, वी आर गोइंग टू स्टडी दैट एंड वी आर गोइंग टू स्टडी द इम्पॉर्टेंट मैनेजमेंट ऑल्सो. So if we look at this is your blue dot cataract. This image is of your zonular or the lamellar cataract. We know both of these are congenital types of cataract. Then the most important risk factors for your zonular or the lamellar cataract, if you can recall, it is maternal malnutrition, maternal rubella, and vitamin D deficiency. So if you are getting this image, you should know the risk factors. And for the management of congenital cataract, you know the management depends on whether your cataract is unilateral or it is bilateral. So if you have got unilateral dense cataract, you have to operate immediately. Or you can say you have to operate it as soon as possible. But if it is unilateral and it is partial, then you can always wait and watch. Remember one thing, whenever you are having partial cataracts, even if it is unilateral or bilateral, you can always wait and watch. But in cases of dense cataract, you have to operate immediately. Bilateral dense, again you have to operate immediately. So how immediate is this immediate in case of dense cataracts? This is, you have to operate it within 6 to 4 weeks of life. Yes, you are going to get the PDF also. So unilateral dense, you have to operate even earlier than 4 to 6 weeks of life. Say you got a child who is, say 4 weeks of life has come. So you will immediately do the investigation and call the child for surgery. Ask the parents for surgery. But in case of bilateral dense, it has to be done up to 4 to 6 weeks of life. Bilateral partial, again you can wait and watch. So partial congenital cataracts, the key is wait and watch. Dense, immediate surgery. You know what is the surgery done in cases of congenital cataract? It is your lensectomy with anterior. Pratik, I have no idea regarding the recording, but I think I am recording it on my behalf. Yes, I am recording it on my behalf, so I'll be sharing it with the NLC group and they'll pass it to all the students. So the surgery in cases of congenital cataract, remember, with the removal of lens, you have to do anterior vitrectomy. This is very important. This is not done in cases of adult cataracts. So along with that, you have to implant the intraocular lens. Next question, what is the power of intraocular lens implanted in cases of congenital cataract. So the power of this lens depends on the age. You have to undercorrect it. Why do you have to undercorrect the power? To prevent myopic shift. See, all these are very important one-liners, questions which are expected in your exams. So we have to undercorrect the power of eyelid to prevent myopic shift. So for a child who is less than 2 years, you have to undercorrect it by 20%. For a child who is between 2 to 8 years of age, you have to undercorrect it by 10%. And for a child who is more than or equal to 8 years of age, you don't have to do any undercorrection. Just remember 2 years, 8 years. इसमें 20%, 10% and more than 8 years, no undercorrection. So I hope I am clear with this slide. This is very important for the exams. Moving on to adult cataracts. So this is your cortical cataract. How does a cortical cataract look? In cortical cataract, you are just going to get peripheral water, clefts like this, like this. This is your characteristic image in which you can see this is the sunken nucleus. Okay, why has the nucleus sunken? Because this cortex has got liquefied, and you all know that sunken nucleus with the liquefied cortex is very characteristic of hypermature Morganian cataract. So this hypermature Morganian cataract, this is your answer. This is your characteristic bread crumb appearance, or what you also call as polychromatic luster. Again, characteristic of posterior subcapsular cataract. So now you know, if you are getting this polychromatic luster like thing on the surface or posterior surface of the lens, if you are seeing like this, then it is suggestive of posterior subcapsular cataract. Another question that is important: what is the most important risk factor? So the most important risk factor for the development of posterior subcapsular cataract is your consumption of corticosteroids. See, consumption of corticosteroids in any form, be it oral, be it topical, be it intravenous, that predisposes the patient to the development of posterior subcapsular cataract. This is what you need to know in normal adult senile cataract. Now moving on to cataracts with specific disease. See, for FMG exams, what all images I have given you, these are very high yielding. It has a high chance of coming in the exam. So just look at the images very properly. If you see this cataract, can you see it is looking a lot like sunflower, right? So this is your sunflower cataract, which is characteristically seen in your Wilson's disease. Other ocular manifestation of Wilson's disease is your Kayser-Fleischer's ring. Why does it occur? It occurs because of copper deposition in the descemet membrane of the cornea. How does it look like? It is yellow brown in color. So if you are given a history of a patient who is having tremors, altered consciousness, and you are getting a picture of a cornea, and they are saying you are seeing something here that is yellow brown ring like concentric ring around the limbus, that means they are talking about Wilson's disease. So this is how you get the questions in the exam. This is characteristic your snowflake cataract. This year, January, they asked, they are very fond of diabetic cataract. Okay, so they asked what is the pathogenesis. Just learn this cataract, it occurs because of the enzyme aldose reductase. Now, what does this aldose reductase do? It converts glucose to sorbitol via your polyol pathway. So for next exams, if they have asked you why does what is the enzyme responsible for the diabetic cataract, you should know what is the product responsible for the formation. Again, it is expected question. You should know that diabetic cataract occurs due to the formation of sorbitol. What does this sorbitol do? It attracts the water inside the lens, and this occurs via your polyol pathway. Then this is your Christmas tree cataract, characteristic of myotonic dystrophy. This is your traumatic or the roseate cataract, and this is your shield cataract, which is characteristic of atopic dermatitis. So if you are getting a picture like this in the exam and they are asking you what is the diagnosis, then you are going to mark shield cataract, because this is a patient of atopic dermatitis. In atopic dermatitis, we characteristically get a shield cataract. So this was about the special types of cataract. Again, very commonly, repeatedly asked in your exams. Then looking at this image is of bacterial conjunctivitis. Sorry, one more previous year question which I forgot to tell you. It was on flax. Now, what is flax? Flax is nothing but femto laser assisted cataract surgery. So, what is the difference between phacoemulsification and flax? What is the laser doing here? See, there's a basic difference. In phacoemulsification, all the steps are done by the surgeon. In flax, steps such as incisions, then your capsulorhexis, and your nucleus fragmentation. These things are done by your laser. Okay. This is your image of bacterial conjunctivitis. Why am I calling it bacterial? If you can see, this is the mucopurulent discharge. So you get questions like in January 2025 exam, you got this question of conjunctivitis. So how are you going to tell which type of conjunctivitis is the cause? So you will tell the cause based on the type of discharge. What does that mean? So if the discharge is mucopurulent, then your cause will be bacterial. If your discharge is mucoid, then your cause will be allergic. And if your discharge is serous, then your cause is going to be viral. What is this? Again, important question. This is your membranous conjunctivitis. Common causes in children, it occurs because of bacteria, which is your Corynebacterium diphtheriae. In adults, this occurs because of Streptococcus hemolyticus. So these are the causes which you should know for the exams. This is your membrane. Now moving on to ophthalmia neonatorum. So if you are getting an image of a child with crusting like this, that means they are talking about ophthalmia neonatorum. So what are you going to get in the question? In the question, you are going to get that a child who is less than 30 days of life, that means a child who is less than 1 month, comes to us with redness and discharge. Then how will you tell that what is the cause of ophthalmia neonatorum? So cause will be told based on the time frame. What time frame of what? Based on the time frame of when the symptoms arrive. So if the attendants are telling me that within 24 hours of birth, the child started having redness and discharge. So my answer would be gonorrhea as the cause. So I will manage it according to the protocol which I have to follow for Neisseria gonorrhoeae. If the child is coming with these symptoms within 48 hours of birth, then your cause will be chemical. If the child is coming later, 5 to 7, then it will be herpes simplex virus, and more than 7 days it will be your chlamydia D2K, which you also call as paratrachoma. Now management, it will depend entirely on the etiology. Allergic conjunctivitis, very important topic for your exam. BKC, spring catarrh, warm weather conjunctivitis. Again, your Jan 2025 question. I told you the discharge in allergic conjunctivitis is either going to be mucoid or it can be ropey or stringy type. Now quickly look at the signs. So this is your cobblestone papillae on the upper palpebral conjunctiva. These are your big papillae. Since these are big, you will call it as giant papillae. Now the giant papillae are the ones that are more than 1 mm in size. You don't need to learn this, but remember these are your papillae. These are perilimbal papillae. What do you call these as? Multiple dots around the limbus. You call these as Horner's Trantas spots. Then another sign you can have in allergic conjunctivitis is your dusky red congestion in the interpalpebral area here. Okay. Other signs are punctate epithelial keratitis, shield ulcer. Why does shield ulcer occur? This occurs due to the macroabrasions because of the papillae. Here the papillae are there, they will rub your cornea and they will lead to the formation of shield ulcer. So in question, if you have got this word shield ulcer, that means they are talking specifically of vernal keratoconjunctivitis. Other thing you can get is vernal corneal plaques, and this is your pseudogerontoxin. This image is of your vernal corneal plaque. So if we look quickly again, you can have either cobblestone papillae, you can have giant papillae, you can have Horner-Trantas spots, you can have dusky red congestion in the interpalpebral area, you can have pseudogerontoxin, you can have shield ulcer, you can have vernal corneal plaque. So if in question any of these is mentioned, that means they are talking about vernal keratoconjunctivitis or warm weather or the spring catarrh. Another important history that is given is it is commonly seen in boys of 5 to 18 years of age, and history of recurrence in every summers will be given. That is why we call it as warm weather conjunctivitis. So this history is very important. So now you know the history, and now you know also the signs of vernal keratoconjunctivitis. Now looking at another important topic, pterygium. Pterygium, look here carefully. If you are getting a mass like this, pterygium has to be a fleshy mass. It can never be a non-fleshy mass. If you are just seeing a yellow dot here, somewhere here, that is not pterygium. That is going to be your pingecula. Pingecula is a small yellow dot. Both are degenerations of conjunctiva. However, if the mass is fleshy, coming encroaching your cornea, your answer is going to be pterygium. So, wing-shaped fold, it is associated with P53 gene overexpression and your UV light exposure. Another important MCQ in pterygium is your Stocker's line. They ask you this, what is Stocker's line? So if you see here, so this line, you can say this greenish line ahead of the pterygium is your Stocker's line. Now why does it occur? This occurs because of iron deposition. Iron deposits anterior to the cap of the pterygium, leading to what you call as Stocker's line. Kayser-Fleischer ring was seen in Wilson's disease. Stocker's line is seen in pterygium. Very important for your exam. Another super important question, I would say, pterygium में what is the type of astigmatism with the rule? I will quickly tell you what is with the rule astigmatism and how, if you get in a question, how will you tell with the rule or against the rule, even if you forget. So remember, whenever your cornea has got more power in the vertical meridia than the horizontal meridia, that means your horizontal meridia is flat and your vertical meridia is steep, then you will get with the rule astigmatism. Why? An important mnemonic or a way to learn is V. If you put 2V, it will become a W. So, whenever this V has got more power, that means this vertical meridia, V stands for vertical meridia. Why does it happen in pterygium? See what happens in pterygium. You have got a mass like this. It is going to pull the cornea. What will happen? Horizontal meridia will flatten. See, FMG people are very fond of asking keratoconus में कौन सा type of astigmatism है, pterygium में what are you going to get, which type of astigmatism. So you need to know these things. There in the exam, just try to remember the pathology. Which axis is getting stretched? So the axis that is getting stretched, what will happen to that axis? That will flatten. The axis that will flatten, so the opposite axis will become steep, right? So whenever you have got a steep axis, so what are you going to get? So if the vertical axis is steep, you are going to get with the rule astigmatism. And if your horizontal axis is steep, then you are going to get against the rule astigmatism. Then you know what is the management. You have to surgically resect this pterygium. Along with that, you have to go for autologous graft implantation. You remove this and from superior part you take a graft and you implant it here. What are the ways to prevent recurrence? Very important question. Using drugs such as mitomycin C, thiotepa and your beta irradiation. So these are the ways you can prevent the recurrence of pterygium. Another important question or another important previous year question, I would say, it has been asked twice in FMG, the grading of diabetic retinopathy. Just remember, non-proliferative, mild non-proliferative diabetic retinopathy, you are going to get only microaneurysm. Now, when you are getting microaneurysms along with some hemorrhages, cotton wool spots, what are you going to call it as? You are going to call it as moderate NPDR. But in severe NPDR, just remember one thing, whenever you are getting 4-to-1 rule of HVI. Now what is this? If you are getting either hemorrhages in all 4 quadrants, or if you are getting venous bleeding in 2 quadrants, or if you are getting irmas in 1 quadrant, that means it is your severe NPDR. In proliferative diabetic retinopathy, you are going to get neovascularization. You know, whenever there is neovascularization, blood vessels, see, I'll try to finish it by 7:30 or so. So, neovascularization, what will happen? The blood vessels will burst. And what are you going to get? You are getting either vitreous or the pre-retinal hemorrhage. So, if in a diabetic patient, the question says that the patient developed sudden painless loss of vision and the patient is uncontrolled diabetic, that means the patient could have got vitreous hemorrhage or pre-retinal hemorrhage. Another thing that is seen in proliferative diabetic retinopathy is your retinal detachment. What will be the clinical presentation in patient of retinal detachment? So, retinal detachment, patient will present with the gradual painless loss of vision. Just remember one thing, in diabetes you are going to get painless loss of vision. In all the arterial and venous occlusions also, in arterial and venous occlusions also you are going to get painless loss of vision. Depends, arterial and venous occlusions are going to be sudden in onset. Retinal detachment is going to be gradual in onset. So this gradual and sudden, painless and painful thing, that changes the whole answer of the question. Okay. So I have told you mild only microaneurysm, moderate you are going to get more than microaneurysm, right? But your 4-to-1 rule of HVI is not followed in moderate. But if your 4-to-1 criteria of HVI is being fulfilled, that means they are talking about severe NPDR. And in PDR, we are going to get hemorrhages everywhere in the vitreous and anterior to the retina, or we can even get your retinal detachment. Let us quickly look how everything looks on the fundus. So this yellowish fluffy structure is your cotton wool spot. These are your hemorrhages. This is your pre-retinal hemorrhage. These new vessels, which are very small and very tough, you know, like a bunch of grapes, we call it. Honestly, we call it that clinically. So this is your neovascularization. That means this is PDR. This is another very important entity. If you are seeing multiple yellowish dots in the area of macula, what are you going to call it as? You are going to call it as clinically significant macular edema. And what is the management of this clinically significant macular edema? The management of this is your intravitreal anti-VEGF injections, because we all know this occurs because of the increased VEGF levels. Then this, if you are seeing areas of retina that are not like the normal, this is the normal retina, this retina is detached. So this is a case of retinal detachment. This is your OCT image of cystoid macular edema. Very, very, very important question. What are the causes of cystoid macular edema? It was even asked in your Jan 2025 FMG exam. So whenever you are seeing what is cystoid, cystoid means you are getting cyst-like spaces inside the retina. And these black cystic spaces, that means this shows that there is some fluid accumulation inside of the retina that is causing macular edema. Now let us quickly look at the causes. So if it is occurring in patients of diabetes, then right corner image. Okay, I'll try not to write there. So if it is occurring in patients of diabetes, then it is called as clinically significant macular edema. If it is occurring after cataract surgery, then what do we call it as? We call it as Irvine gas syndrome. This was your Jan 2025 exam in which you got this OCT image and they gave you the history that the patient underwent cataract surgery. Now you tell the name of the syndrome. So the next question, next reason is your posterior uveitis and your venous occlusions. And very important is the management of cystoid macular edema. If it is occurring due to any cause, say you get this image, they ask you the management, it is anti-VEGF injections. See, when you are studying with me, just all of you just try to imbibe as much as it is possible, so that you can correct maximum questions in your exams. These are the questions they ask. You know, they कभी आगे पीछे करके इन्हीं क्वेश्चन से, इन्हीं टॉपिक से they keep on repeatedly asking you the questions. So I am also covering the most common previous year questions in this session. So if you revise this, so I think you will be done with the previous year questions, important topics, and even your important images for the exam. This is your image of central retinal vein occlusion. What do you call this thing as? This is your tomato splash appearance. Now, what is the most important risk factor? It is increasing age and hypertension. Then, what is the management of a patient with CRVO? Management, just remember, the most important complication of CRVO is your cystoid macular edema. So, what will be the management? It will be anti-VEGF injections. If you look here, then only in a part of retina we are getting the blood. So what is this entity called as? This is your branched retinal vein occlusion. So whenever you are getting hemorrhages everywhere, multiple big hemorrhages, that will be your central retinal vein occlusion. Whenever you are getting in a specific area, that is going to be your branched retinal vein occlusion. The next is your pale retina with your cherry red spot, and along with that, here if you see, there is some cattle tracking of blood in the veins. So what will be the diagnosis? Your diagnosis is going to be central retinal artery occlusion. We know it occurs in the patients who have got atherosclerosis or any previous heart disease. So basically there is a thrombus or embolus. Where is it going to come from? Either from the heart or from the atherosclerosed blood vessels. Just remember, thrombus embolus कहाँ से आएगा, and if there is occlusion तो क्या cause होगा. So if you try to think about the pathogenesis, तो आप easily risk factors make out कर सकते हो. Now if we look at the management, CRAO is an ocular emergency. So management involves sudden decrease in pressure. How can you decrease the pressure? You can decrease it either by doing ocular massage, number one, very important. Number two, by decreasing the intraocular pressure. How can you decrease the intraocular pressure? By giving IV hyperosmotic agents. What are the IV hyperosmotic agents? IV hyperosmotic agents are mannitol, acetazolamide. Other thing you can do is you can do anterior chamber paracentesis, or you can ask the patient to inhale carbogen mixture. Now what is carbogen? Carbogen mixture is 95% oxygen and just 5% carbon dioxide. So basically when the patients hyperventilate in a polythene bag, that will behave similar to a carbogen mixture. This is your, if you see, this part of your retina is normal and this part is pale. So what is your diagnosis? This is a case of central retinal artery occlusion with the macular sparing, which occurs due to the sparing of your cilio-retinal artery that supplies your macula. Now another previous year question, very important one, is your Keith-Wagner-Barker classification. You should know that this classification is for hypertensive retinopathy. Now grade 1 is going to be generalized vasoconstriction. Just remember one thing, whenever the BP rises, what happens? There will be generalized vasoconstriction of all the blood vessels of the eye. However, when it changes to focal constriction, then it becomes grade 2. Okay, so grade 2 is having focal constriction, AV nicking, again due to focal constriction. Grade 3 is going to have proper well-defined cotton wool spots, hemorrhages. Then it is even going to have hard exudates. And what does grade 4 include? Grade 4 includes nothing but bilateral optic disc edema. Again, to simplify it, I would say if in question you are getting generalized vasoconstriction, then it is going to be grade 1. Focal vasoconstriction, grade 2. Grade 3, let's skip grade 3 for once. Grade 4 is nothing but your bilateral optic disc edema, and everything that remains, that is your grade 3. So grade 3 will include cotton wool spots, hemorrhages, hard exudates, even your copper and silver wiring, they are included under your grade 3. This is a characteristic image of a patient with the retinitis pigmentosa. Most common inheritance of a patient of retinitis pigmentosa is sporadic, and the worst is your X-linked recessive. Now if we look at this image, retinitis pigmentosa has got a triad. What is the triad? Number 1 is your waxy optic disc pallor. Then number 2 is your generalized narrowing of the blood vessels. Number 3 is your bony spicules in the periphery of the retina. I would not even call it periphery, I would say mid-periphery. Somewhere, if you see, this is the posterior pole, so just outside of the posterior pole. So this is the classical triad of retinitis pigmentosa. Again, you should know for your exams. And next image, this OCT appearance, what does it show? It shows multiple cystic areas. So this image is of cystoid macular edema. Again, this is your image based question for the exam. This is nothing but your flower petal appearance. Again, very characteristic of cystoid macular edema. This is nothing but your central serous chorioretinopathy. What is that? So whenever you are getting an OCT image in which you see there is localized and a well circumscribed separation of the layers of retina, that means it is central serous chorioretinopathy. And this is how the cystoid macular edema looks. You don't call it cystoid macular edema. This is the most common mistake we do when we are preparing for your entrance exams. So what are the FFA images you see? This is your ink blot pattern and this is your smokestack pattern, just like a mushroom. So you also call it as mushroom pattern. So they will ask you what are they can either give you images or they can ask you as one liner for the FFA pattern. What do you call it as? In CSR and CME. In CME we have got flower petal appearance and in CSR we have got both ink blot and the smokestack pattern. These, what are these? These are your drusens and these are very characteristics of your dry ARMD. Now we know the risk factor for dry ARMD is your increasing age. What is the management? Nothing but your ARMD cocktail for dry ARMD. What is ARMD cocktail? Nothing. We are going to just ask the patient to take multivitamins for the eye. What does that include? It includes vitamin A, not A. It includes vitamin D, vitamin E, zinc, copper, lutein and zeaxanthin. This red patch of hemorrhage on the macular area, what do you call it as? This is your wet ARMD. What do you call this patch as? This patch is your CNVM patch. What is the management? So whenever you are seeing any blood in the macular area, your management is going to be anti-VEGF injections. This is your area of retinal detachment. So this is an image of detached retina. This is an ultrasound which we call as B scan. So basically B scan is an ultrasound of the posterior segment of the eyeball. So what are you seeing here? You see that the retina has got detached. Okay. What are the types of retinal detachment? So we have got different types of retinal detachment. You can have tractional retinal detachment. You can have rhegmatogenous retinal detachment. Most common one is your rhegmatogenous, or you can have exudative type of retinal detachment. The one which you should know now for the exam is your rhegmatogenous. What are the risk factors? Any peripheral retinal degeneration such as lattice degeneration or your snail track degeneration of the retina, or it can also occur in patients with the posterior vitreous detachment. Management involves, we know we have to provide external tamponade via the buccal, internal tamponade via the air or the gas, and along with that you have to drain the subretinal fluid. Along with that you have to do laser or the cryotherapy of the hole. That is not very important. You should just know the images. Yes, tear is important for rhegmatogenous. See, primarily this is for the FMG students, but the images definitely they are asked both in NEET PG and your FMG exam. So this Another high yielding topic for the exam is your retinoblastoma. It is the most common primary intraocular. They ask you in the exam what is the most common primary intraocular tumor in children. So that is your retinoblastoma. If they ask me what is the most common primary intraorbital tumor in children, that is going to be rhabdomyosarcoma. Why am I stressing on these? Because these both are your previous year questions on FMG. What will be the most common presentation? This is going to be leukocoria, right? Leukocoria, what are the differential diagnoses? Just remember congenital cataract and Coats disease and your retinoblastoma. Along with that, even in ROP and your cases of retinal detachment, you can have leukocoria. Then what is the gene responsible? RB1 gene. This is the child showing left eye with the leukocoria. Then retinoblast 2 arrangements. Another expected question. This question was NEET PG 2024 question. So this can be asked in FMG this time. So we have got two types of histopathological arrangements. Basically the cells that make up this tumor are your retinoblast. So if they are well arranged and they have got a true lumen here. If you see the cells here are well arranged and in center of that you have got this true lumen. So this is your Flexner Wintersteiner rosettes. But sometimes what happens, you are getting a mass of entangled cell and there is no true lumen. There is just eosinophilic center. Then what will you call it as? Homer-Wright pseudo-rosettes. Another important question or another important hint that you get in the question is your CT scan will show calcification in these tumors. Now talking about the management of these tumors, if the tumor is unilateral advanced, then you will have to enucleate the eye. However, if the tumor is bilateral, then obviously you can't remove both the eyes. You are going to go with the chemotherapy, most common being the VEC chemotherapy. Now what is VEC? V stands for vincristine, E stands for etoposide and C stands for carboplatin. So your VEC chemotherapy. Then moving on to another important question which you get almost every year. If you are having 2 sessions in 1 year, so 99% आपके दोनों sessions में you are going to get question from visual field defects. Now if there is a visual field defect that is at the level of optic nerve itself in the retina, you are going to just get a central scotoma. If you are going to have a defect here in the optic nerve behind the retina, you are going to get monocular vision loss. Just remember one thing, in visual field defects, if the damage is occurring nasally, you are going to get the visual field defect that will be temporally. For the temporal thing, you are going to get visual field defects nasally. So this is vice versa. Then here at the level of optic chiasma, you are going to get bitemporal hemianopia. Just remember one thing that is going to act as a ramban for this question. The only situation in which we get bitemporal hemianopia is your optic chiasma. Rest everywhere behind the optic chiasma, we are going to get contralateral homonymous hemianopia. So if there's a lesion optic tract, again contralateral homonymous hemianopia. If your temporal fibers, they are affected. We know temporal fibers के लिए the radiations they loop downwards. What are we going to get? We are going to get a pie in the sky. What will you call it as? You are going to call it as superior quadrantopia. If your parietal fibers, they are affected. Parietal fibers, they go upwards and backwards. Where are you going to get? Since the fibers are going up, you are going to get a pie in the floor, or what you also call as contralateral inferior quadrantopia. However, if the tip of the occipital cortex is involved, what are you going to get? You are going to get contralateral homonymous hemianopia with the macular sparing. Occipital cortex, just remember, you are going to get macular sparing. Why? Because the macular representation is at the tip of the occipital cortex. So until and unless your tip of the occipital cortex is damaged, you are not going to get any visual fields defects that are involving your macula. Okay. Then the next important question is your... No, I am not from Hyderabad. I am from Haryana. So next question is your origin and insertion of extraocular muscles. We know we have got 4 recti: superior rectus, inferior rectus, lateral rectus, medial rectus, and we have got 4 oblique: inferior oblique and your superior oblique. So all the recti, they collectively originate from your common tendinous ring of Zinn, or what you call as annulus ring of Zinn. Remember one thing, say this is the equator of the eyeball. So the recti are going to insert anterior to the eyeball and they are going to insert anterior to the equator of the eyeball. And the oblique, they insert posterior to the equator of the eyeball. Inferior oblique, it arises from the floor of the orbit. Superior oblique, it arises from the sphenoid bone. Then another previous year question is, what is the distance of various recti from your limbus? So my mnemonic for learning this is Mills, mother-in-laws. According to that, if we talk about the distance of medial rectus from the limbus, it is 5.5 mm. Inferior rectus is 6.5 mm. Lateral rectus is 6.9 mm. And superior rectus is 7.7 mm. Looking at the actions of extraocular muscles, just remember the recti are adductors. How do you learn that? Just remember this thing. R-A-D, rad. So recti are adductors. Superiors are intortors. Okay, recti are adductors and superiors are intortors. And so if you look at the action of superior rectus, so superior rectus, it is a recti, so it will adduct. Intortor, superiors are intortors, so it will intort the eye. And just remember one thing, whenever it comes to recti, they will go according to their name. What does that mean? That means if I am talking about the superior recti, so it will elevate. However, if I am talking about superior oblique, it will depress. So if we talk about superior oblique, again, oblique is going to be an abductor, depressor and an intortor. Medial and lateral rectus, they have got only one question. So medial rectus will do adduction and your lateral rectus is going to do abduction. Again, your inferior rectus, recti, adductor, superiors are intortors, so inferiors are your extortors. I told you recti, they go by their name. So if it is inferior, what is going to happen? It is going to depress. Inferior oblique, it will elevate. Inferior rectus is going to depress the eyeball. So again, they ask you the action of extraocular muscles in your exams. Then binocular single vision, just remember one thing, we have got 3 grades of binocular single vision. MFS. Now what is M? Grade 1 is simultaneous macular perception. So in grade 1, what is seen is, we are seeing 2 different images with 2 different eyes and the brain is fusing it into one. What will you call it as? You will call it as simultaneous macular perception. Remember, in grade 1, different images. So in grade 2, what are we going to get? In fusion, we are getting 2 similar images but incomplete in some aspect. So if we look here, these images are similar. However, they are incomplete. So when the brain is seeing two similar images that are incomplete and fusing it into one, that will be grade 2 of your binocular single vision, which we call as fusion. And grade 3 refers to your stereopsis, which you also call as depth perception. So how will you remember which one is grade 1, grade 2, grade 3? That is by the mnemonic M, F and S. Amblyopia, another important repeatedly asked question in your exams. So amblyopia, just remember 2-3 key points. Whenever the difference in the visual acuity between the two eyes is of at least 2 lines on the Snellen's chart. So this is a very important thing, that suppose one of my eye is reading 6-9, the other one at least has to read 2 lines less than that for it to be called amblyopia. Then in amblyopia, your fundus is going to be absolutely normal. And if we talk about the power difference between the two eye in amblyopia, that has to be more than or equal to 2.5 diopters. So whenever the power difference between the two eyes is a patient who comes to me with a difference in the visual acuity in the Snellen's chart of at least 2 lines, power difference of more than or equal to 2.5 diopters, and along with that, if the fundus is normal, that means the person is having amblyopia. Now, what are the tests for amblyopia? One is your neutral density filter test, the other one is your crowding phenomena. Management of amblyopia involves patching or your occlusion therapy. How is it done? It is done depending on the age of the child. Say a child is of 4 years, then you will patch that eye. What are you going to do? Which eye are you going to patch? You are going to patch the normal eye. Why? So that the lazy eye or the myopic eye starts to work. So you'll patch the normal eye for 4 days, and for 1 day you will not patch it. You will open both the eyes. Suppose the child is of 2 years, then you will patch the normal eye for 2 days and you will not patch it for 1 day. Then again for 2 days you will patch, 1 day will be patch free period. Again for 2 days you will patch and 1 day will be patch free period. So this patching or the occlusion therapy is the most important for your amblyopia. Then another important thing which you should know here is power difference. When it occurs more than or equal to 2.5 diopter, then there is a chance of amblyopia. What is the difference in image size? How much is the difference in image size? That leads to diplopia. When the difference in image size between the two eyes is more than 5%. What is the power difference in the single eye? See, power difference in itself means between the two eyes. Say one of my eyes has got, if I am the patient, so one of my eyes has got spectacles of minus 1.75 diopters and my other eye has got spectacles of plus 2 diopter. Then if we look at the power difference, so what is the power difference is going to be? Power difference is going to be 3.75 diopters. Why? If you look at these signs, they are different. So whenever there is a power difference of more than 2.5 between two eyes, that means the eye that is reading less or the eye that has more power, that will be your amblyopic eye. Say one of my eyes has got minus 2 and the other eye has got minus 4. Then you will not call this eye amblyopic since the power difference is just 2. However, if it changes to 2 and 5, then you will say my left eye is amblyopic. I hope I am clear. Another thing is, this is the image of your Maddox rod. So what is it used to do? It is used to check So what is Maddox rod used to check? Maddox rod is used to check whether the diplopia that is occurring is crossed or it is uncrossed. So what is cross diplopia? What is the condition in which we get cross diplopia? How does a cross look like? It looks like this. So cross diplopia is seen in exotropia. Exotropia has also got a cross, and a cross diplopia also has got a cross. Uncrossed will be seen in esotropia. Then if we look at this image is of your esotropia. This image is of your cross fixation in lateral gaze. Now what is cross fixation in lateral gaze? For the children who have got congenital esotropia, what happens is when they look like this, both the eyes are esotropic, what will happen? Right eye will see the left side of the field and the left eye will see right side of the field. This is called as cross fixation in the lateral gaze. Power difference, again I will tell you. Suppose this is the right eye, this is the left eye. So right eye has got power of -1 diopter. Left eye has got power of -3 diopters. What is the power difference between the two eyes? It is 2 diopters. So here there is no amblyopia. However, if it changes to 1 diopter and -4 diopter, what is the power difference? 3 diopters. Does the patient have amblyopia? Just check it. If the fundus is normal, then you can say that the patient has got amblyopia. So this is the power difference which you see कि कितने पावर का दोनों आईज में स्पेक्टिकल्स है. देन यू सब्ट्रैक्ट इट एंड देन यू गेट द पावर डिफरेंस. सो am I clear, Hari? So this is an image of your lacrimal drainage apparatus. Another important question. These are your upper and the lower vertical and your horizontal canaliculi. Then comes your common canaliculus. This is your lacrimal sac, nasolacrimal duct. They ask, where does the nasolacrimal duct open? So it opens in the inferior meatus of the nose, and there is a valve here. What is that valve called as? That is called as the valve of Hassner. Okay, this is just the anatomy. I'm not talking about DCR here. I'll talk it in subsequent slides. Then talking about the tear film function test. What are the tear film function tests? They want you to know Schirmer's test and tear film breakup test. In tear film breakup test, what do we see? So basically we stain the eyes of the patient with fluorescent stain, and we look for the appearance of first dry spot on the cornea. So what we do is we stain the tear film and then we look after how many seconds the first dry spot has appeared. So what will that indicate? That indicates the tear film that was initially equally spread on the eye. Whenever it breaks, so what will happen? When it breaks, you will get a dry spot. So this is what you call as tear film breakup test. So normally it is, more than 10 seconds. Schirmer's test, important for your exam. No, it doesn't open in the middle meatus. It opens up in the inferior meatus of the nose. So I think I forgot to include the image of Schirmer's test. So Schirmer's test image was given. So if you are seeing a white strip of paper here with some markings, and part of it is folded here inside the eye and a part of it is hanging, that means we are doing the Schirmer's test here. So we are looking that after 5 minutes, what is the amount of wetting on the strip? So if the amount of wetting is more than 15 mm, that is normal. Less than 15 mm is suggestive of dry eye. Another thing to learn to mug up is your rose Bengal staining, which is again your tear film function test. Then the test for watering eye, here we put pressure like this and we do regurgitation test. Then important for your exam is your lacrimal syringing test and its interpretation. So say this is your lacrimal drainage system. They say we have done the syringing, but your fluid is coming out from the same punctum. What does that mean? That means the occlusion is somewhere here. So what will happen? The fluid will go like this and it will come out through the same punctum. So what will you say? You will say that the patient has got obstruction in the upper canaliculus or the lower canaliculus. Then another interpretation is, if your fluid is going but it is coming out of the opposite puncta. What does that mean? Opposite puncta means your fluid has, this is your common canaliculus, lacrimal sac and your nasolacrimal duct. So if your fluid is coming out from the opposite puncta like this, that means there is some obstruction here at the level of common canaliculus. What is the normal interpretation? These are the abnormal interpretation. Normal interpretation means what will happen? The fluid will flow from here, it will go here and then into the inferior meatus of nose, and from there it will go into the throat of the patient. So if they are telling in the question that syringing was done and the patient felt something in the throat, some water in the throat, that means everything is patent. His lacrimal apparatus is absolutely fine. Then what is Jones dye test 1 and 2 used for? Just remember this name for the exams. It is used to test whether you are having partial obstruction or complete obstruction, or you are having any functional problem in the lacrimal drainage system. Okay, so this is used to differentiate between these three conditions. Then congenital dacrocystitis, most important is how will you manage it. So you are going to do Krigler massage. This is done up to 1 year of age. Lacrimal sac, no. See, what are we doing in syringing? We are just taking a blunt cannula and we are just checking the patency of the system. And DCR is a surgery. So syringing is a procedure. It is a test used to see what? It is used to see the level of obstruction. And DCR is a proper surgery that is used to open up the system and create alternative pathways for your fluid to pass. So Krigler massage is done up to 1 year of age, and when is lacrimal syringing done? It is done between 1 to 2 years of age. The syringing and probing are done. Jan 2025 question, they asked you in a child with congenital dacrocystitis, probing was done and we got soft stop. What is the management? So what is soft stop? So basically, whenever you are, this is your lacrimal drainage system. When are you going to get soft stop? Just try to think. If you have put your probe here like this, if there is some occlusion at the level of common canaliculus, what are you going to get? You are going to get a soft stop. So what will you do? You will bypass this pathway. What is that called as? That is called as conjunctival DCR. So just remember, soft stop, it is seen when your obstruction is at the level of common canaliculus. Common canaliculus is just a tube. So when you hit a tube, it has some obstruction. So it will appear that there is some soft obstruction. So management will be your conjunctival DCR. DCR is contraindicated in less than 4 years, always done more than 4 years. Or what you can do is you can put silicone tube stents. Another thing you can get is hard stop. What does that mean? That means you have touched the lacrimal bone. That means the obstruction is at the level of lacrimal sac. How will you manage it? You will manage it by doing external DCR. So they ask you in the question, you get a question, they can ask you, you have got hard stop, what will you do? Will you do conjunctival DCR, external DCR? Will you wait and watch? Will you reassure the child? What will you do? Hard stop, external DCR. Soft stop, conjunctival DCR. Just remember these two lines. Then walls of the orbit. I know all of you know this diagram very well, so I don't think there's a need to repeat it here. Then what are the structures passing through the superior orbital fissure? Superiorly, inferiorly, and through the annulus of Zinn. So this is your circle, is your annulus of Zinn. You know annulus of Zinn is the tendinous ring from which your four recti pass interiorly. Then if we talk about the structures that pass superiorly, just remember superiorly your liver function tests, they pass. So LFT stands for lacrimal nerve, frontal nerve, and trochlear nerve. So this is your LFT. Through the annulus of Zinn, what structures pass? The remaining things, that is your oculomotor nerve. We know that oculomotor nerve has got two branches, superior and inferior. Then which nerve is remaining? Your nasociliary nerve and your abducens nerve. Just remember, inferiorly nothing, no nerve passes. Superiorly, your liver function tests, they have to be right. That means your lacrimal, frontal, and your trochlear nerve. All the remaining things, they will pass through your annulus of Zinn. The next is your signs seen in thyroid ophthalmopathy. Another very important slide for your exam. Dalrymple sign, when you have lid retraction in the primary gaze. Von Graffe is the lid retraction in the down gaze. Stellwag sign. What is stuck? Is my video not coming properly? Okay, audio is also fine. Okay, so Stellwag sign is, you mean net issues at my end? Okay, great. Stellwag sign is decreased frequency of blinking. Coccus sign is your staring appearance. Enroth sign is the puffy swelling of the eyelids. Gifford's is the difficulty in the eversion of upper eyelid. Just remember these signs for your exams. You are going to get a question on the signs also. Either you get it as a part of surgery or as a part of ophthalmology. Next is this is your image of preseptal cellulitis. So in preseptal cellulitis, what will be the history? You will get a history of a woody swelling of the eyelids. So you will get a history that there is a woody swelling, patient complains of a woody swelling of the eyelids. Along with that, the patient has got pain. However, the ocular motility, your pupillary reaction, everything else is normal. That means they're talking about preseptal cellulitis. What is the management? Management is your oral antibiotics. If you look at this image, again there is a woody swelling, there will be pain. However, when your ocular motility is decreased, your pupillary reactions, they are not normal, and when you are getting this conjunctival swelling, what do you call this as? You call it as conjunctival chemosis. So basically the fluid is collecting beneath the conjunctiva. What does this indicate? This indicates that your eyeball has started involving. Now your eyeball has started involving. What will be the diagnosis? Your diagnosis is going to be orbital cellulitis. Now what is the management of orbital cellulitis? You have to immediately hospitalize the patient and go for intravenous antibiotics and MRI brain. Why MRI brain? Very important question. To rule out cavernous sinus thrombosis. What does that indicate? That indicates that cavernous sinus thrombosis is a very common complication of orbital cellulitis. Now, another important question which they keep on asking repeatedly is your blowout fracture of the orbit. So, if you are seeing a history, most important is your history of blunt trauma. This is number 1. Number 2, what is the most common wall that is involved in the blowout fracture? That is going to be your inferior wall of the orbit. Now, if you are seeing a shadow here beneath the fracture site of the inferior orbital wall, or what you call as the teardrop sign, that means that the patient has blowout fracture. So what is the characteristic sign that you see on X-ray? That is your teardrop sign. However, on CT scan, the structure that is appearing white here, it will be black. This is not ink blot. Ink blot sign is seen in central serous chorioretinopathy. That is a part of retina. Here we are talking about orbit. So teardrop sign is seen as white structure on X-ray. On CT scan you see it as a black structure coming down from the inferior wall of the orbit. So what are the clinical features? You will get a history of ecchymosis in the question, edema, emphysema, all indicative of fracture. Diplopia, when your extraocular muscle has entrapped. Then enophthalmos. Again, this occurs when your extraocular muscle has entrapped in the site of the fracture. When are we going to manage it surgically? So whenever there is diplopia, there is a large herniation of contents or the incarceration of the orbital tissues, or whenever the enophthalmos is more than 3 mm. So any of these conditions, you have got a teardrop sign in the question, what are you going to do? You are going to manage it surgically. But if there is only teardrop sign, there is no diplopia, there is no incarceration of orbital tissue, there is no enophthalmos, then you leave it conservatively. First line is conservatively, but only in these conditions you have to go for the surgical management. Then orbital tumors, again very important for your exam. They ask most common intraorbital tumor in adults, that is your cavernous hemangioma. But the most common intraocular malignancy in adults is your malignant melanoma. Most common intraorbital malignancy in children is your rhabdomyosarcoma, and the most common intraocular malignancy in children is your retinoblastoma. So these are all again your previous year questions of FMG exam. Now looking at the ocular manifestations of blunt trauma. So this is asked almost every alternate year. If you look here, what has happened? The iris has separated from its root. What do you call this condition as? This is iridodialysis. This was your Jan 2025 question. This is your hyphema. What is hyphema? Hyphema is blood in the anterior chamber. Again, this is your hyphema. What is this? This is your retinal tear. If you look here, what is this? This is nothing but your retinal detachment. Exactly, you are right. This is D-shaped pupil. If you look here, this is making a D. But in question, they didn't ask you D-shaped pupil. D-shaped, everybody can tell. They asked you the name of this condition. So this condition is referred to as iridodialysis. Then, if you see here, what is not there? So this is the empty structure. What is normally present here? Normally, optic nerve is present here. So what has occurred after trauma? This is what you call as optic nerve head avulsion. See, hyphema is blood in AC, and hypopyon. Hypopyon is pus in the anterior chamber. Pus is hypopyon, hyphema is blood. Both are seen in the anterior chamber. Both are seen here. Both settle down due to gravity. But if it is blood, you will call it hyphema. If it is pus, you can call it hypopyon. See, if you are having doubt in these basic structures, and if you have time, then you can visit my YouTube channel. It is by name of Sargam Chhabra. You are going to get different topics in which I have given you, say, retina. In retina, I have just mentioned you the important topics, what you need to know for the exam, what you don't need to know. So you have videos over there. You can go there, you can watch it. Then is your ptosis, another important question which is repeatedly asked. This eyelid is your ptotic eyelid. Now, what is the question they ask? They ask you Marcus gun jaw winking phenomena. Why does it occur? This occurs due to the aberrant regeneration of the fifth cranial nerve into the levator palpebrae superioris. What will be the characteristic history that is given? You will get a, see, iridodialysis and roseate cataract are two entirely different things. Iridodialysis means your iris has separated from its root, and roseate cataract means you are getting a cataract on the surface of lens. You want me to show? Just a second, I'll show you. This is your traumatic or the roseate cataract, star-shaped cataract. Iridodialysis, if you remember, that is different. Again, I'll show you what is irid. Yes, both are caused by trauma, but if it is in iris, that is iridodialysis. If it is occurring as a part of cataract, then it is roseate cataract. So, if we were talking about Marcus Gunn-Jovinkling phenomena, history will be given that there is improvement in the ptosis when the child either sucks the milk or the thumb, or when the child is breastfed. So why does it occur? It occurs because of the innervation of the levator palpebrae superioris by a fifth cranial nerve. What is the management of Marcus Gunn-Jovinkling phenomena? Levator palpebrae superioris muscle resection along with the sling operation. What is overall management of ptosis? When is Fasanella servate operation done? It is done when the LPS function is good and you have got mild ptosis. Levator resection, when it is done when you have got moderate ptosis. When is sling operation done? When the LPS, levator palpebrae superioris, muscle function is bad and you have got severe ptosis. This image repeatedly asked in your exam. This is your image of entropion. This is your image of blepharitis. Again, blepharitis. This, as I told you, this is your Schirmer's test. What is it used to test? This is used to test or your condition which is called as dry eye. Then this is your stye or the hordeolum externum. So if you are seeing a pus point on the external surface of the skin, or you can say on the hair follicle base, then it is called as stye or the hordeolum externum. What will be the management? Nothing. Management will be your oral antibiotics. Remember one thing, stye is painful. On the other hand, if you are seeing a mass here, no external pus point, no pain. What are you going to call it as? You are going to call it as chalazion. What is the management? Incision and curettage. Here there is no well-defined lesion or well-defined pus point. So you will call it as chalazion. This is your well-defined pus point. This is your stye. Moving on to congenital glaucoma. These are your, this is what you call as buphthal. See, it is not drainage. It is incision and curettage. You curate out the material. So this is buphthalamus. What is buphthalamus? It is enlargement of the cornea that is occurring secondary to raised intraocular pressure. What are these? These are horizontal lines in the Descemet's membrane. What do you call as? H horizontal, H for Habs stria. Another line seen in the Descemet's membrane are your Vogt stria. How do they look like? V Vogt, V for vertical. These are characteristic of keratoconus. What is the management of congenital glaucoma? Which is the drug that is contraindicated? Another one-liner question. Brimonidine is contraindicated in congenital glaucoma. Why? because it causes CNS depression. So how will we manage it? We manage it surgically. What are the surgeries that are done? Trabeculectomy is the surgery of choice. What are we doing in trabeculectomy? We are creating an alternative pathway. Okay. This image is of your short tonometer. This image is of your Goldman applanation tonometer. Yes, you have to give the incision vertically in the calagion. Why? Because we have got meibomian glands. And how are the glands? They are present vertical. So if we give a horizontal cut, what will happen? You are going to cut all the glands. And we know meibomian glands are important for the tear film of the eye. So what will happen? You will get dryness. So that is why we incise. So suppose you have incised. At max, what will happen? You have cut just one meibomian gland, right? But if you give a horizontal incision, what will happen? You have cut all the meibomian glands. So that is why in calagion, you give a vertical incision and then you curate it out. This is your Goldman applanation tonometer. How do you see the intraocular pressure? So basically, you see these two Myers. So important thing to learn to see is what is the reading? When will you say that this is the reading of the intraocular pressure? We call it when the inner circles of the two Myers, they coincide. So whenever the inner circles of the two Myers, they coincide, that will give you the, is it? You try to see it again. The inner circle of this Meyer and the inner circle of this Meyer, they have to be coincide and they have to coincide, and the point at which they coincide, that will be your reading of intraocular pressure. This is your gonioscopy. It is used to view the angle of anterior chamber. One liner question is, what is the principle of gonioscopy? It is based on this principle of total internal reflection. What are the structures that you see? STSCR. This is the mnemonic. Schwalbe's line, trabecular meshwork, scleral spur, ciliary body band, and R stands for the root of iris. So this is what you see from anterior to posterior. Is it breaking for others also? Okay, great. Let's look at perimetry. So this is your visual field. So just remember the sequence of visual field defects in glaucoma. If you want to see how do they occur, then you can watch my rapid revision series on glaucoma. I have explained one by one how are the defects they appearing. But for this class, I'll quickly just write the name. So the initial one to occur is your isopter contraction. Then is your bearing of the blind spot. Then is your paracentral scotoma. This is followed by your Siedel's scotoma, then you get arcuate scotoma. This is seen in Jerem's area. So what is the other name of this? You can also call it as Jerem's scotoma. Then you get double arcuate scotoma. Then you get temporal field is central or the tunnel vision is left behind. And another important one-liner is, which is the last field to go? That is your temporal fields are the last to go. So IBP SAD T. IBP SAD T, isopter contraction, bearing of blind spot, paracentral, sedals, arcuate, double arcuate, and your tunnel vision. See, I'm trying to cover it all for you people. If you have any doubts, you can ask me at the end of this class, or if you want me to show any other image, that also I can do at the end of the class. So last year this image was given in the question, that the patient came with pain, redness, swelling, nausea, vomiting, and severe headache. If you look, what are the signs you can see? You can see there is circumcorneal congestion and your pupil is mid-dilated and it is vertically oval. What is your diagnosis going to be? Your diagnosis is going to be primary angle closure glaucoma. One very important thing which I think you people should know is, suppose if you are getting this type of congestion 360 degree, which you call as circumcorneal congestion, and the patient has come to emergency with pain. So if you will see at the pupil, if with circumcorneal congestion your pupil is mid-dilated and vertically oval, then your diagnosis is going to be primary angle closure glaucoma. But if your pupil is myotic, that means it is very small, then your answer is going to be anterior uveitis. So a patient of both anterior uveitis and angle closure glaucoma will present with a lot of circumcorneal congestion and pain. But looking at the pupil, I can tell whether this is a case of angle closure glaucoma or anterior uveitis. So if your pupil is small, it is a case of anterior uveitis. If your pupil is mid-dilated and vertically oval, it is going to be a case of primary angle closure glaucoma. Now let us quickly look at the management of different types of glaucoma. So the first line drugs for the management of primary open angle glaucoma are your prostaglandin analogs. If we talk about the first line management of a patient of primary angle closure glaucoma, what will that be? It will be IV hyperosmotic agent such as mannitol. Just listen to what I'm saying. I will tell you, I will explain you every word I'm writing. Then if you talk about the drug of choice or the first line drugs for primary angle closure glaucoma, what are they going to be? It is going to be pilocarpine. If you ask me the definitive management of a patient of primary angle closure glaucoma, what is it going to be? It is going to be laser peripheral iridotomy in the involved eye. This is your laser peripheral iridotomy. So via laser, what are we doing? We are making a hole in the peripheral iris. This is followed by the laser peripheral iridotomy in the other eye as a part of prophylaxis. So what happens in a patient of angle closure glaucoma? When the patient will come to me, the pressures are going to be very high. Say in late 30s to 40s. Normal pressure is between 11 to 21 millimeter of mercury. So when the pressure is very high, what will I do immediately? Or I will say, what will I do as first line? I will have to decrease the intraocular pressure. Okay, so how will I do sudden decompression? Sudden decompression of the eyeball. I'll do it via your hyperosmotic agents, that is mannitol. Then if you talk about the drug of choice for primary angle closure glaucoma, that is your pilocarpine. But if you ask me the definitive management for angle closure glaucoma, I will say it is laser peripheral iridotomy in the involved eye first. Then after a week you do it in the uninvolved eye as a part of prophylaxis. So these all three are different questions. Now looking at anterior uveitis, this is what you call as hypopyon. These are the cells. This is your festooned pupil. These seen are your keratic precipitates. These are seen on the back surface of corneal endothelium. And what is the characteristic area in which they are seen? This area is characteristically called as Arl's triangle. Then these are the iris nodules. So if you are seeing P on the pupillary border, no, Vossius ring is not a part of uveitis. Remember, Vossius ring is a part of trauma. What happens? Suppose there is blunt trauma. This is your iris, this is your lens. After blunt trauma, what happens is iris, it went behind and it did hit the anterior capsule of lens. So what will happen whenever the iris comes in contact with lens? It will put some pigments on the anterior surface of lens. So those pigments will be in the form of a Vossius ring. So it is seen in trauma, not in uveitis. So if you are seeing nodules on the pupillary border, P for pupil, P for Kopes nodules. And if you are seeing here on the base of iris, is my voice lagging? You will call it as Busaka's nodules. This is your candle wax dripping, which is very active mode. Please check your internet connection because others are not facing this problem. So you might have a problem with your internet. Maybe you can disconnect and reconnect again. So these candle wax drippings like these white things, these are very characteristic of sarcoidosis. This is your pizza pie appearance, which is very characteristic of CMV retinitis in a patient of AIDS in which the CD4 plus cell count is less than 50 cells per mm². Then this is nothing but your headlight in fog appearance, which is very characteristic of toxoplasmosis infection in HIV patients. Another important topic that is repeatedly asked in your exam is sympathetic ophthalmitis. So most important thing which you have to learn is in sympathetic ophthalmitis is there has to be a history of penetrating injury. It can't occur without a history of penetrating injury. Then what is the earliest symptom? The earliest symptom is photophobia. Earliest sign is your retrolental flare. What is the posterior segment manifestation? These yellow white nodules. These are seen beneath the retina. And what do you call these as? You call these as Dehlen-Fuchs nodules. So these are very characteristic of sympathetic ophthalmitis. If you ask me about the management, so prophylactically you can enucleate the eye with the injury. There is some lagging problem. I know there's some problem with my pencil. I don't know what has happened to my pencil today only. So as a part of prophylaxis, you can enucleate the eye with the injury, and as a part of treatment, what are you going to do? Since it is a case of inflammation, so you have to give steroids by all possible routes. So if I am suspecting that, suppose the patient has got penetrating injury in the right eye, and I am suspecting there are high chances, there are earliest signs of sympathetic ophthalmitis in the other eye. So what I can do is I can either prophylactically enucleate the eye, but sometimes what happens is patient comes late. So in such cases, the patient has got a full-fledged sympathetic ophthalmitis when the patient comes to me. What will I do? I will give steroids by all possible routes. What does that mean? I will give IV also, I will give oral also, I will give topical also, as much steroids as I can. What is this condition called as? So if you are given a history of any intraocular surgery, or a patient that is immunocompromised, or a patient that has got uncontrolled diabetes. So if in question you are given these key points and you are seeing hypopyon, this pus in the anterior chamber, right? This hypopyon, along with severe circumcorneal congestion, and there's a history that the patient underwent cataract surgery or any glaucoma surgery or any other surgery 3-4 days back. What will be your diagnosis? Your diagnosis will be your endophthalmitis. Yes, you are right. Answer will be endophthalmitis. What is the management of endophthalmitis? Intravitreal antibiotics along with the antifungals. Sometimes this doesn't act. So what will you do? You will remove the source of infection. How will you remove the source of infection? By doing what you call as vitrectomy. What are you doing in vitrectomy? You are removing whole of the vitreous. So what is the one repeated question that is asked in FMG is, what is the prophylaxis for endophthalmitis? Remember one thing, the single most important factor for prophylaxis is instillation of (5% povidone iodine in the conjunctival sac for 3 to 5 minutes prior to the surgery. So this is the single most important factor for the prophylaxis of endophthalmitis. You are going to get multiple options, but if they ask you the most important, that is this. What is this image of? This is your image of bacterial keratitis, or what you call as bacterial corneal ulcer. If you see, the ulcer is circular, well circumscribed, right? But if you see in this case, the ulcer has got a dry looking appearance, or what you also call as parchment paper appearance. See, I would just request all of you to focus on the subject and not on other things. We have a lot of time for other things. We just have 5 days, 1 week left for the exam, and we should focus on this important topics. Then we are going to have, see, this is the main lesion, and we are going to have multiple small lesions away from the main lesion. That is your satellite lesions. And your ulcer, here it is circular. Here the margins are feathery. What does this indicate? This indicates your fungal keratitis. See, hypopyon will be present in both bacterial and fungal keratitis. But the hypopyon in bacterial keratitis, it is sterile and mobile. But in fungal keratitis, it is not mobile, or you can say immobile, and it is asterile. This is your characteristic dendritic ulcer. Important thing is that dendritic ulcer is seen in which infection? Herpes simplex virus infection. Then another important question, that one-liner question they ask you, the base of the dendritic ulcer, it stains with fluorescein, and the margins of the ulcer, they stain with the rose Bengal dye. Okay, this is your stromal necrosis, again seen in patient of herpes simplex virus keratitis. This is characteristic keratitis in a disc-like shape. So what will you call it as? You will call it as disciform keratitis. Looking at the management, so for management of dendritic ulcer, you are going to give only antivirals and geographic margins and herpes simplex virus keratitis. And you have to avoid steroids. Steroids are contraindicated in dendritic ulcer. But if the patient has developed stromal necrosis or disciform keratitis, then you have to give both antivirals and a proper steroid cover. This, if you are getting lesions only on the half side of the face, that means this is a case of herpes zoster virus. Most important thing or the most important sign which you should know in this is your Hutchinson's sign. So what is Hutchinson's sign? It says that if the tip of the nose is involved by skin lesions, then the involvement of cornea is highly there. Why does it occur? This occurs because of the involvement of the nasociliary nerve. Again, what will be the management? Management will be high dose antivirals. So the dose of antivirals which we were giving in herpes simplex virus keratitis, we have to double that dose in herpes zoster ophthalmicus. Then this is your characteristic ring ulcer. Ring ulcer is very characteristic of Acanthamoeba keratitis. Now, what they ask you two questions. So, if there is a history of contact lens user, what is the most common organism involved? Just there is a history of contact lens user. The most common organism is going to be Pseudomonas. But in question, if they say that there is a history of contact lens user who washed the contact lenses in tap water. So as soon as this term tap water comes in picture along with the contact lens, your answer changes from Pseudomonas to Acanthamoeba keratitis. Now, quick points about keratoconus. These are the vertical striae. I told you these are your Vogt striae. Then looking at the association of keratoconus, associations include Down syndrome, Turner syndrome, Marfan's, Ehlers-Danlos, osteogenesis imperfecta, vernal keratoconjunctivitis, blue sclera, ectopia lentis and aniridia. This is your Jan 2025 question. They asked you the clinical presentation. So what happens is your cornea has become like this. So the effective axial length of the eyeball will increase, and what will the patient present as? Progressive myopia, and because of this central thinning, there will be irregular astigmatism. Just learn this thing. Then you will have a scissor reflex on retinoscopy, and because the cornea has thinned out, so there will be prominence of corneal nerves also. If you are getting this sign, that means they are talking about keratoconus. What does this sign say? So if a patient of keratoconus, we ask the patient to look down. There will be a V-shaped bulging of the lower lid in down gaze. That is your Munson sign. What is Fleischer's ring? I have told you Kayser-Fleischer's ring. That is different from Fleischer's ring. Fleischer's ring is seen in keratoconus, but KF ring, Kayser-Fleischer ring, is seen in Wilson's disease. So this occurs because of F. Fleischer's, and we write iron like this scientifically. So this is characterized by iron deposition on the base of the cornea. This is your Rizzuti sign. So this is the temporal side. Whenever you are throwing light from the temporal side, it goes, hits the cornea, and you will get a conical image here on the nasal side. This is your Placido disc test. What is it used for? It is used to see the corneal curvature. So this is how your normal cornea looks like. You will have these structures or the rings, they are equally spaced. But in a patient of keratoconus, because of the thinning, these will change from circular to vertically oval. Then management option, if it is progressing, yes, bow tie pattern is seen on pentacam, not on Placido disc test. So if it is progressive, you have to go for C3R. What is C3R? It is collagen cross linking. Another thing you can do is you can implant rigid gas permeable lenses, which are your Rose K lenses, or you can go for intrastromal corneal rings, which you call as INTACs. And penetrating keratoplasty, when is it done? It is done when the patient has developed corneal opacity secondary to keratoconus. Then you replace that cornea. Now, if you are getting an image like this, what is this? You are seeing multiple black sutures here, and you can see a junction or the interface. So what is this surgery called as? This is your penetrating keratoplasty. What are the media of storage? This is your characteristic media, which you should know, MK media. This is your Boston keratoprosthesis. Again, there are multiple sutures. This is your one cornea, this is another. That means this is the recipient's cornea and this is the cornea you have put from the donor, and in between the two we see something with the hole. So this structure is what you call as Boston keratoprosthesis. Looking at aphakia, just look at these points. It leads to high degree of hypermetropia. Normally the dioptric power of the eye is 60 diopter, out of which around 43 to 44 diopters is contributed by the cornea. Rest 16 to 17 diopter is contributed by your lens. So whenever there is aphakia, what will happen? The dioptric power of eye is reduced to 44. There will be total loss of accommodation. Patient will have symptoms of erythropsia and synopsia. Most important is there will be jack in the box phenomena and a roving ring scotoma. These are very characteristics of aphakia. And the image magnification, if you use spectacles of high power, that will be by 30%. Another important question is Purkinje images. Normally, we have got 4 Purkinje images in you or me. One is by anterior surface of cornea, other is by posterior surface of cornea, anterior surface of lens, and posterior surface of lens. So, in patients of pseudophakia, you are going to get how many Purkinje images? You are just going to get 3. 1 and 2 from cornea and 3 only from intraocular lens. And in patients of aphakia, how many Purkinje images you are going to get? Only 2. Then myopia, just look at the fundus findings important for the exams. So fundus findings include peripapillary, this is peripapillary atrophy. Then Foster Fuchs spots are here on the macula. This is whole your tigroid fundus. There can be lacquer cracks, posterior staphyloma, and some peripheral retinal degeneration such as lattice and tail tract degeneration. I have told you these both predispose to rhegmatogenous retinal detachment. Then this is what you call as Sturm's conoid. Now what is Sturm's conoid? So whenever the light it reflects from a toric surface, what does it lead to? It leads to the formation of Sturm's conoid. What does it say? So the light rays in one meridia will focus at a different point and the other meridia will focus at a different point. Okay, so this is your Sturm's conoid. This is your Jackson cross cylinder. If you look here, there are certain markings and some power written here, and it has got a handle also. It is used for the subjective refinement of refraction. Then moving on to retinoscopy or skioscopy or shadow test, just remember no movement means myopia of 1 diopters. With the movement means either the patient is emetropic, hypermetropic, or myopia of less than 1 diopters, and against the movement means myopia of more than 1 diopters. What is this? This is your Priestley Smith mirror retinoscope. What is this? This is your streak retinoscope. So what are they showing? They are showing that you are moving the retinoscope here and the image is moving like this. This is your against the motion. With the motion means both your retinoscope and the image inside the patient eye, they are moving in the same direction. So you can get these images also. And neutral means you will see glow in whole of the pupillary area and there will be no movement. Xerophthalmia, very important question for your exams, repeatedly asked. So earliest symptom of xerophthalmia will be night blindness, and the earliest sign will be conjunctival xerosis. Then this is your Bitot spots. This, if you can see here, cornea is very dry, so you call it as corneal xerosis. This, if you look here, this part of the cornea, it looks like it has melted, right? Or it has weakened. So what will you call it as? You will call it as keratomalacia. And these multiple white dots in a patient of keratoconus, in a patient of xerophthalmia, what do you call it as? You call it as xerophthalmic fundus. So these are the things you can get. They can ask you the earliest sign or the symptom, or they can ask you the management. So management was asked in this Jan 2025 exam. Management includes, since there is xerosis or what you call as dryness, so you have to give local lubricants. For a patient of keratomalacia, since it was looking also like an ulcer, what are you going to do? You are going to manage it just like a corneal ulcer. So the most common cause of vitamin A deficiency is your malnutrition. So what are the causes? Maybe it might be kwashiorkor, or it might be due to some chronic diarrhea, or maybe due to celiac disease, or maybe due to IBS. So if there is any underlying cause of malnutrition, you have to treat that. Now looking at the vitamin A therapy, for a child between 0 to 6 months, you have to give 50,000 international units orally. 6 to 12 months, 1 lakh international units. And for a child who is more than 12 months, you have to give 2 lakh international units orally. IM dose is half the dose of oral in all the age groups. So when is vitamin A therapy given? It is given in on day 0, day 7 and day 14. But see, the dose for both the treatment and prophylaxis is same if you look here. But what is the difference? Vitamin A for treatment we give 3 doses, but for prophylaxis we give 1 dose every 6 months. Another important thing is, if you look at the vaccination schedule, then the first dose of vitamin A is given at 9 months with measles, and the second dose is given at 18 months with DPT, and the third one is given at 2 years. So sometimes what might happen is, if the child is even improperly vaccinated, then also what happens if the child is not properly vaccinated? So then also the child can have vitamin A deficiency, because vaccination के साथ we were even supplementing the child with vitamin A. So if the child didn't go for vaccination, then that automatically means he didn't get that dose of vitamin A that was supposed to be given with that vaccine. So in Jan exam, there was a child who was incompletely vaccinated, and the child was malnourished secondary to measles, and they asked about the treatment. So basically in such a case, what you have to do is, you have to ensure that the child is properly vaccinated. You have to give supportive treatment if the child is having chronic diarrhea or celiac disease or gluten sensitivity or inflammatory bowel syndrome or whatever. And along with that, you have to give treatment dose of vitamin A, and that too on the proper scheduled days. Then next is your direct and indirect ophthalmoscopy. These are very important. This is your direct ophthalmoscope, and this, what the doctor is doing here, is your indirect ophthalmoscopy. So in direct ophthalmoscope, you visualize up to the equator. Direct ophthalmoscope mein what happens is, you are just getting a smaller area, but in indirect ophthalmoscope you are visualizing even up to the far periphery of the retina, because magnification in cases of direct ophthalmoscope is 15 times, but in cases of indirect it is 4 to 5 times. So since the things are small, so what you can do is, you can view a larger area in indirect ophthalmoscopy. Image formed in direct ophthalmoscopy is virtual and erect. Indirect ophthalmoscopy, it is real and inverted. Direct ophthalmoscopy can't be used in hazy media. Remember, in hazy media we do indirect ophthalmoscopy. Then for stereopsis we do indirect ophthalmoscopy. Central 30 degree is visualized by indirect ophthalmoscope, but with direct only central 10 degree is visualized. You can ignore the principle. Just remember one thing, in indirect ophthalmoscope a convex condensing lens is used. This is your Snellen's chart. What is it used to see? It is used to see far or your distance vision. And then you have got near chart also. What is that called as? That is called as Jaggers chart. This is your image of staphyloma. And this is your image of the sea. This can either be your staphyloma or it can be your scleromalacia perforans. So basically in both the conditions what happens is your sclera thins out, and what happens because of that, the underlying uveal tissue, it becomes visible. So what will I mark in the question? So if I am giving a proper history of prior rheumatoid arthritis or gout in a female, then I will mark my answer as scleromalacia perforans. But in history, if I am given history of either say trauma or the fact that it is present since birth, then my answer will be staphyloma. This is a previous year question. So you should know when to mark staphyloma and when to mark scleromalacia perforans. Now quickly, in the last 5-7 minutes, let's quickly look at the instruments. This was asked in your last year exam. This is your wire speculum used to open up the eyelids during surgery. This is your limbs speculum. This is used to hold the cornea or the sclera during any intraocular surgery. Right, this is limbs forceps. This is the magnified version. So in limbs forceps, here you get the tooth. Then these are your Aruga's forceps used in ICCE, which is outdated now. The only indication for ICCE in today's date is subluxation or dislocation of the lens. These are your stout and the small forceps. These are your epilation forceps. Then this, if you look at these two structures, they look almost similar. But if the interior end has a guarding knob, what will you call it as? This will be your muscle hook, which is used in the squint surgery. And this is your lens hook, again used in ICC. This is nothing but your Desmere's lid retractor, used to retract the lid. This, if you look here, it has got paws like a cat. So this is your cat paws lid retractor. This is your Mueller's retractor. This is your needle holder, and its name is Castrovillo's needle holder. You can ignore this. This is not used nowadays. This is your Castrovillo's calipers. So basically it has got various markings here in mm. So what you do is, if you have to do any surgery, you have to give intravitreal injection, you have to look at the distance from the limbus. You have to give such things at a particular distance from the limbus. Or say you are making an incision. So how will you measure that distance? You will measure that distance through your Castroviejo's calipers. Then this diamond shaped instrument or the thing is your keratome. This structure or this instrument is your crescent. This is your side port. This is your V-lance blade. Sorry, this is not your side port, this is your MVR. This is your, where you see one and then two bends like this. This is your cystitome needle. So this is sharp here. If you look here, this is blunt. This is your hydro dissection cannula. These are your corneoscleral scissors. They don't have a sharp bend, they have a very smooth bend. If you look here, these have a sharp bend. What do you call these as? These are your Vanna's scissors. This is your lid clamp, or what you also call as entropion clamp. This is your chalazion clamp, and this instrument is your chalazion scoop. These both are your wire vectors used to take out the lens. This is your irrigation and aspiration cannula, also known as Simcoe cannula. You can ignore this for the exams. Then the one with just two ends like this. This is what you call as iris repositor. This doesn't has any teeth, and this is your McPherson IOL holding forceps. If you look at these two structures, the one that is sharper is your chopper. This is used in phacoemulsification. And this is your IOL dial. This is your Kelly's punch. This is used in trabeculectomy for trabeculectomy surgery, which is done for glaucoma. This is your lid massage. This is your punctum dilator and your Bowman's cannula. Then this is your this is big and stout. So this is your lacrimal bone punch. If you look here, this looks like a curate and this looks like a dissector. So this is your lacrimal bone curate and dissector. This is your optic nerve guide, also called as your enucleation guide, and this is your evisceration spatula. So this was all about the important topics, important instruments, all the previous year questions, repeated questions, and everything which you need to know for your upcoming exam on 26th. So I hope I made ophthalmology a bit easier for you and you didn't get much bored. And I hope to see all of you clearing the exam. All the very best for your exams, and let's meet while preparing for your PG exam. All the very best. Believe in yourself. Have faith that you know everything. If in a question you are stuck, just try eliminating the options. So sometimes you stuck even at two options which you are not able to eliminate properly. Try to think about the disease or the options. You'll definitely come to the answer. तो ये अगर directly हमें ना आता, go via your elimination method. And evisceration versus enucleation. See, in evisceration, I'll just show you here. So in evisceration, what are we doing? This is your optic nerve. In evisceration, we are just cutting this part and we are taking out everything. So what is left behind? This much part of the sclera and your optic nerve intact is left behind. This surgery is called as evisceration. But at the same time, if you are removing whole of the eyeball, including the sclera and a part of the optic nerve, so what are you left with? You are just left with a part of optic nerve stump is left behind. Then this is called as enucleation. So in enucleation, you are removing whole of the eyeball along with the part of optic nerve. But in evisceration, what are you doing? You have just cut a part of cornea and sclera and you are scooping out everything from the eyeball, all the inside structures of the eyeball. So what are you left behind? You are left behind with the outer framework of the sclera and your intact optic nerve. So this is the difference between evisceration and enucleation. Just do one thing, go home today, revise this PPT, and trust me, you will be able to clear around 70% of the questions in your exam. And all the very best. Let me know how the exam went. And if you have any doubts in any specific topic I have told you, you can view my YouTube videos for that specific part. And my YouTube channel is via name of Sargam Chhabra. So, hope to see you on the other end very soon. Okay, bye.